Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Hips and knees. When we don't feel them, that's good. And when we do feel them, it's because we have pain. And when we have pain, we have to do something about it. So I brought someone who is really an expert at this. It's called orthopedics. And if you're an orthopedic surgeon, you get a chance, if you specialize in hips and knees, to work with people like Dr. Bruce Janke. So welcome to the show, Dr. Janke.
Thank you.
So I know when you did our Cure Symposium, you talked about why you like to do this. This was something that was fun for you even as a kid. You didn't do it as a kid, but you liked the whole idea, right?
Exactly, yes.
You could have been a carpenter, you could have been an orthopedic surgeon, right?
One of the two, yes.
Right, but your dad, who's a famous doctor, he certainly geared you, no, you want to be an orthopedic surgeon. So
that's right.
So in doing this, you've come a long way. Even though you're young, there have been a lot of other ways that people had their hips and knees repaired years and years ago. What was the most archaic one?
I don't know if it's archaic, but yeah, they've been doing hip replacements since the probably almost 50 years, now 60 years, and they've done it traditionally with what's called the posterior approach, which has been tried and true. It's been around for a long time, and it does have a very good success rate.
And what does that consist of?
Well, it means a large incision through the back of someone's hip near their rear, and it involves splitting muscles or cutting muscles or dividing them in order to gain access to the hip joint to perform the replacement.
And so, but there must have been problems with that from the very beginning, too. There wasn't just one ABC. I mean, it's been developed over the years, hasn't it?
Right. There's always potential problems when you do any kind of operation, whether it's orthopedics or otherwise. And we always try improving on some of the potential risk or the complications associated with any operation.
But when you're dealing with, so what is your favorite, hips rather than knees? I mean, it seems like years ago someone specialized in hips and some with knees.
You can specialize in hips or knees. We specialize in joint reconstruction, so it can be hips or knees and sometimes even shoulders.
Joint reconstruction. Of course, it all looks different. I mean, the knee from the hip to the joint.
It is. The knee is more like a hinge and the hip is more like a ball and socket. So there are differences, obviously.
But the shoulder, that's an interesting thing you bring that up, because I know people who've had more problems with shoulder reconstruction than with hips and knees.
Sometimes a shoulder operation is not that it's harder to do, but the recovery is longer, sometimes more difficult than a hip or a knee replacement.
Is it because anything inside the mechanism?
It's because the shoulder is much less constrained. It's much more difficult to reproduce a normal anatomy or a normal function of the shoulder as opposed to a hip or a knee.
Now, you use something you call a ANITA table.
Yes, for hip replacements.
It's just for hip replacements.
Well, the table is primarily for hip replacements, but it can also be used for hip fractures or femur fractures or other traumatic type of surgeries.
And why is the table so good?
The table is good because it helps us during the surgery. It's like having an extra assistant, allows us to position the leg in certain positions that we may not be able to do without the table.
So it controls the system.
It controls the leg.
It controls the leg because, well, yes, but if the person is anesthetized, aren't they kind of out of it? Does it matter?
Well, they are out of it when they're anesthetized. So the anterior approach that I do can be done with or without a table. Depends on your training. And the people who use a table, such as myself, use it because it makes the operation easier to manipulate the leg and get it out of the way when we're doing the procedure, therefore making it easier for the surgeon to perform the operation.
I see. So for years, though, this is a new system, isn't it? ANITA hasn't always been around, has it?
ANITA's been around almost since the year 2000, I believe, somewhere around there.
But you've been doing this before that.
Well, I've not been doing it. I've been doing the anterior approach since about 2006. But anterior approaches to hips have been around for almost 30 years. In Europe, they've been doing it for a long time. It's an approach that they use for pediatric surgery or certain hip operations. Now we've just modified it and made it work for the anterior hip replacement.
I see. So, well, it's funny. I go online to something called MedGadget, and it's really fantastic. And I'm learning about, now, a lot of these things are not probably FDA approved yet, but they're in the works, and it's amazing what's coming online.
You're right.
So heaven only knows, you may now be able to wave your hands at somebody's hip, and if you have the right energy or magnetism, just gets fixed 1, 2, 3, right?
It'd be nice to do it that way.
Well, of course, I have seen people who have suffered with hip replacement, and so it's not always perfect. I mean, sometimes it is, and sometimes they're still limping 6 months later. Why is that?
A lot of answers.
Okay, start with...
Some of it depends on the patient, what they were like before the operation. How bad was their hip? How stiff was their hip? Was their hip shorter or longer? Were they on pain medicines beforehand? When we do the operation, we are replacing the ball in the socket. We're not changing the muscles, the ligaments, the tendons, so they still may be stiff. Sometimes your brain has a memory, so if you limped for a long time before surgery, you may limp afterwards, even if you're not having pain. And sometimes there are potential risk or complications from the surgery as well. You can get scar tissue, you can get tendinitis. Sometimes they can be longer or shorter. Sometimes you can dislocate. So there are potential risks with the surgery, but overall, about a 93 to 95% success rate with hip replacement surgery.
All right, well then let's go to knee replacements. Are knee replacements more difficult, and is it are you more prone to maybe not have it as perfect and you can't walk as well?
It's not that the operation is more difficult, but it's a more difficult operation to recover from. They tend to hurt more than a hip replacement. They require a lot more physical therapy after as well. But again, it's a very successful operation with numbers in the mid-90s as far as long-term success rates. So both of them are very successful. But unfortunately, sometimes patients do have pain or they require more therapy.
I had just attended a lecture, as I spoke to you about, and something came up as far as the rehab. And he made it very light about the rehab. And I always thought rehab was extremely important.
It depends on the operation, whether it's a hip or a knee, and it depends on how the patient was beforehand as well. With the hips that we're doing with the anterior approach, really less therapy is better. Patients tend to do equally as well. They don't have to go to the rehab facilities. They can go home. With a knee replacement, the therapy is much more intense. We have to work hard to get their range of motion, to get their strength back.
And they also discussed, someone said, I love to do, one of the people in the audience said, I love to do skiboarding or?
Skiing.
Well, more than skiing, something else. Okay, but it was like skiing. And the orthopedic surgeon said, not a good idea.
There's certain activities that we maybe did in the past that may or may not be appropriate after you do a hip or knee replacement. And a lot of times I'll tell the patients that if you are a good skier beforehand, you can go back to skiing. If you're a good tennis player, you can go back to play tennis. The problem is not with the sport, whether it's tennis or golfing or racquetball or whatever, it's falling. And you could fall down the parking lot, you can fall down skiing, and that's where you may potentially injure your hip or your knee that was recently replaced.
Yeah, that's very important. My guest is Dr. Bruce Janke. He is a board-certified orthopedic surgeon, and he hangs out at the Broward Health North Hospital Medical Center, and he's very well respected for people who are looking for knee, hip replacement, shoulder replacement, something that's right there with orthopedics. I suggest you call him for an appointment. I'll give you his phone number. Remember, this is Pencil Talk Radio. Get your pencils out. Write it down. It's 954-942-4433. That's 954-942-4433. Or you can go on their website, eastcoastortho.com. eastcoastortho.com. Okay, so let's say that we've had hip replacement already, and somebody falls, or knee, whichever one you want. What do you do then? Let's say they damage.
Well, hopefully that nothing had happened, but if they damage it, it depends on what kind of damage occurs. Usually, if you're going to be concerned, it's they broke around the implant, either the hip or the knee implant. And that becomes problematic because then we have to stabilize the old implant, either a longer one or a major operation with plates and screws or cable. So it's much more difficult when they break a hip or a knee around an implant.
So, but does it work?
It does work, sure.
So you can get them back. And the biggest thing, of course, is for people not to fall, whether they even had a hip or knee replacement. Falls seem to be such a problem nowadays, and I don't know why.
It's a good question. We don't have the answer. I think, we're living longer. As we get older, sometimes we lose some of our faculties, we lose some of our strength, and that may be an issue as well.
And the vision, they don't see where they're going.
Exactly.
Well, then the other question I think comes up is how long is this going to last? These shoulders, hips. I mean, I don't know about the shoulders, but let's just stay with the hips and the knees. So let's say someone that you are going to do this for today. How long do you expect a knee replacement or a hip replacement to stay?
Well, generally speaking, with a hip replacement, there have been some studies out there that show they can last up to 20 or 30 years in individuals. Knees tend to wear out a little sooner, but you look about 18 to 20 years with a knee replacement.
Okay, so now let's say is it the same as someone falling? Let's say that somebody has done everything right and it's just wearing out. What wears out?
Well, usually with the hip or the knee, they're made of a couple different materials. There's a metal material, there's a plastic material. The metal tends not to wear out, but the plastic does. It's called polyethylene. And over time, it wears out just like the tire in a car will wear out. And hopefully, if you catch them early enough and everything else looks good, you can go back in and just change out the liner or the plastic.
Okay. Why don't they make something that won't wear out?
They've tried, and that's sometimes when the companies get into difficulties. They tried metal on metal, that had some issues. They've tried ceramic on ceramic, which is also a good bearing surface, but has some potential risk of squeaking. So, we've tried making the implants better. We've tried to make them last longer, but sometimes, problems arise. So right now, what most patients are getting was what's called a ceramic ball on a polyethylene liner, which, like I said, should last 20 to 30 years.
You said something about squeaking? I mean, I'm thinking, so someone's walking in, they're going squeak, squeak, and you're saying, who is that, right? That's my knee?
It's a problem that can occur if you get what's called a ceramic on a ceramic hip. We're kind of to veer away a little bit from that now because of squeaking issues. But it's a good bearing surface, and in a young 20-year-old, it may be the bearing that could last them potentially their lifetime.
Oh, well, there's a lot to this, but I think back many, many years ago where people did not have knee operations or hip operations. They wound up in a wheelchair.
Correct.
So that's not what has to happen anymore. That's been the marvel of science and medicine, isn't it?
It's true. I mean, hip and knee replacement is one of the most rewarding surgeries that there is around the world, actually, as far as improving patients' quality of life and getting them back to function like they were prior to having problems or issues.
And so, I don't know in your case, but how old is too old to have this done?
I'm not sure you could put an age limit. A lot of it depends on the individual. I've operated on 90-year-olds who are still healthy, who are still active, and who can qualify for a hip or knee replacement. I've turned away younger patients because not just their age, but because their overall health. They have heart disease or pulmonary disease or other issues where they're just not a candidate. So I think more importantly is not look at the age, but look at the individual.
That's very good. I'm so glad that you said that because, in my profession as a gerontologist, I've always heard people say, you can't do this, it's too old. And I said, what do you mean too old? Let's look at really what too old means. And of course, there are people who are way overweight. And let's talk about that. And you're nice and trim, and I'm sure that that's what you would like your patients to be before, if possible, you operate.
There's no question that a thinner individual or patient is a lot easier to operate than a heavier one. But, everyone has their different lifestyles. And as we get older, our metabolism slows down. It's difficult to keep the weight off. And it's hard to tell someone, I'm not going to operate unless you lose weight. We encourage them to. But the excuse is always, I can't exercise because I have hip or knee pain.
Well, that makes sense, right? So they have to do something. Now, my husband actually had, years ago, he's 93, but he did have he's had 4 hips over a period of time, and he's had his knees. And his knees are, as you said, I think it's like going on 25 years. But he was told when he had his hip and knees, mostly the knees, he said, can I go back and play tennis? And the orthopedic surgeon said, sure, you can do that, Bill, but if you do, I'll see you again very soon.
From what we tell our patients, doubles tennis is okay, and we don't discourage it. You can still go back to do that. We don't want you running or jogging on a regular basis, like 3 times a week, running on the treadmill or even outside. It will wear out the implant sooner than later. We're trying to give you something that will last almost your lifetime, or 20 or 30 years. And if you do too much too soon, it may not last as long.
Well, let's go back to the weight issue. So now the weight, though, is bearing, the bearing weight on your knees, your hips. I mean, that's pretty hard.
Well, so even if you're overweight before the operation, it's more problematic as far as your pain levels. Maybe it wear it out sooner. If you do the operation and you're still overweight or morbidly obese, some studies show that can wear out the implant sooner than later. And there's other issues as well. Not just the fact that it wears a joint, it has to do with diabetes, has to do higher risk of infection, high risk of complications. So we do encourage our patients, if possible, to lower their body mass index or their weight prior to undergoing any operation, not just for the hip or knee, but for their overall well-being.
And to stop smoking.
Yes. That's another risk factor for having complications perioperatively.
Do you see that as someone who's a smoker? Let's say they don't have those other problems. What do you see when you go in? You don't see any signs of smoking.
No, you don't. You won't see it in a hip or knee. You won't see nicotine in the hip or something like that.
Yeah, right.
But there are a lot of studies that show it affects the ability to heal properly and wound issues and complications. So we encourage our patients to try to stop smoking.
Yes, well, that's excellent. Okay, so now what I wanted to ask you, though, is are there pediatric orthopedic surgeons?
Yes, there are.
So let's say there's a football player in high school. Is that something you would do, or is that kind of...
Once they're in high school, they're already acting like an adult. Their bone is matured, so we treat them like an adult. Pediatric in general is younger patients, much younger than high school.
Okay, so if someone has a son or a daughter who's exercised too much or done some things, they could still come and see you.
Of course.
All right, so let me give some more phone numbers out. This is Dr. Bruce Janke, and he is a board-certified orthopedic surgeon, and he works out of Broward Health North. The phone number to call him if you like an appointment or a consultation is 954-942-4433, or go to eastcoastortho.com. All right, now that you know who you are and you've done all this, is there another profession in medical, let's say another specialty, that you would like to do, or are you just so happy with this that you're not going to try anything else?
Not going to try anything else.
No brain, none.
Nope. The nice thing about orthopedics is it involves a lot of different areas of the body, so there's a lot of diversity with the hip, the knee, or the shoulder, or traumatic injuries. We're always being stimulated. We're always doing different things. It's not just one organ system.
All right, so when you were going to medical school and you had your cadaver, did you love your cadaver?
Loved it.
I ask you that because I am part of something called science care, and I'm giving my body over to science, and I want to be somebody's cadaver.
That's good for you.
Because it really means something, doesn't it?
It's amazing that people donate their bodies that we can learn. It's amazing.
So you thought of... So this is... I know it's a little eerie that I'm asking you these questions, but I'm just curious. So do you really know that person by the time you've finished your first year? Or
you know the body inside and out. You don't know the individual.
No, I know. Yeah. But you do know the body. And,
of course.
And if you looked at your your fellow student next to her, does it look the same?
Once you get down through some of the layers, the muscles, the anatomy, all looks pretty similar, yes.
So, okay. So if you had a dog, I know you're not a veterinarian, but dogs, veterinarians are specializing in orthopedics.
Yes, they are.
And they're doing a lot of the same things. They don't have knees. I guess they have hips.
They do hip and knee replacements on dogs, sure.
They do?
Yes, they do.
Okay. Well, see there, that was another one. Well, I just think science is fabulous because what you all are doing in your field and other fields, they are making people, they're allowing people to live much longer, but not just living longer, but to living a higher quality of life.
Right. It's all about quality of life, and that's what we're trying to improve.
Yeah. And so I was thinking, and I know your dad, and he is so terrific. And he was in a different field. He was in the field of cardiac surgery, and he did some very special things, I know. I want to just share a little bit of that with people.
With my father, oh boy.
Oh boy.
I can build up his ego even more.
Build up his ego, right. I'm going to put this on YouTube anyway, so you'll be able to play it for him.
When he was doing his residency, there wasn't open heart surgery at that time. And he had to learn, and they practiced on animals, and he was one of the pioneers in open heart, doing bypass surgery. He was the first to do it in Broward County. And he got some of the more complicated cases, and he had a very, very good track record. He was a very skilled surgeon. I saw him actually when I was in 5th grade doing surgery, and it was amazing.
You got to watch him?
I got to watch him, yeah. Do open heart surgery at 10 years old,
kidding.
10 years of age.
Oh, that was exciting for you. So you knew then that you didn't want to do heart. Well, you thought about it probably.
Open heart was probably my backup or my second choice. It's amazing. It really was watching him, do what he did and what he could do for patients in their lives. And at the time when they weren't really doing open heart, and he was very skilled.
Yeah, and of course now we have So we have replacement in all fields, and also he did. His reputation is sterling, and I was just curious. Do you have any brothers or sisters?
I'm one of 6 kids.
I didn't realize that. And are any of them doctors?
Nope, I'm the only one.
Oh, so he really loves you.
I hope so.
But I mean, you followed then in, what made them not go into medicine, do you think?
Maybe they're smarter than me. I don't know.
Oh, you're so bad. No, I don't think so. But he's, and then of course, Dr. Janke is Peruvian, which is very exciting because I've had a lot of history with Cusco, Machu Picchu, and so he's an interesting man. I mean, he knows your father, but he's very quiet. But he's so smart. But he lets everybody else talk.
He's taking it all in.
So it must have been a wonderful life for you to have that with him. But let's just get back to what you do now at Broward Health North. Is it important for you to have a certain amount? You can't have too many patients a day. There used to be a story, with certain kinds of health organizations, they were demanding that you do, a lot. And that's not really fair, is it? Because you can't really give a person all the attention you need to.
We try to, but you're right. You can't. If you're overloaded with patients and you can't spend as much time as you'd like to with each individual patient. Medicine is changing tremendously as far as healthcare, health insurance, reimbursements, and it puts a lot of pressure on us, on the implant companies, and on the hospitals, which is too bad because what we can do for patients is really amazing. And we hope that it goes in the right direction for the future.
Well, like knees and hips, we don't want to wear you out.
And we don't.
No, but that it is very hard. And as I was told by some physicians, orthopedic surgeons, but the demands really was too great. They just couldn't do. Some of them were doing 6, 7 a day. I guess you heard. Are you doing that?
Sure. I'll do 5 on Mondays or 6 on Mondays. And then,
are you kidding?
Nope.
You really are.
We're just efficient, though. I mean, we have 2 rooms, so we're able to do that. I mean, each operation is only probably an hour. So it's really not it's that much time for the surgery itself, and you're taking time in between to go see the family members and do your dictation. So it may sound like a lot, but it's not that stressful on us.
You're just you're a good guy. I mean, because you're just always so positive. But I know it must be a little difficult. Can we talk about the difference in having anesthesia and having
It's regional. Anesthesia is a general topic. You can have a general anesthetic or you can have a regional anesthetic.
Yeah, that's what I was looking for.
And, general, obviously, they put you to sleep and use a tube down your mouth or throat to help you breathe during the operation. You're completely out during the procedure. The other technique is a block where they regionally numb up or localize the anesthetic to the hip or the knee. So it's done with the spinal, typically. You can do some regional nerve blocks further down, like for the foot or ankle, but it's hard to numb up an entire hip or an entire knee by a local block into that area. So a spinal is the way to have that regional done.
So a spinal is, and who actually injects the spinal?
The anesthesiologist will do that. And if you talk to the anesthesiologist, they say that both are just as safe or equally as effective. And for me as a surgeon, it doesn't matter to me whether the patient's asleep or whether it's a regional like a spinal, because the operation can be done under either one safely.
But the spinal, the person isn't totally, I mean, they'll
give them a twilight. So they'll be still awake. They won't have a tube in their mouth or throat. They are awake, but they give them a medication to help them relax or go into like a twilight zone.
I see. Because on an elder patient, I've always felt that once they go into anesthesia, it takes a little longer for them to be restored.
Sometimes. The anesthesiologist will say it has nothing to do with that. But obviously, if you talk to patients and family members, they'll say, my mom had a hip fracture. She underwent general anesthesia, and she never came out the same. So I think most of it's anecdotal. A lot of times it depends on the mental status of the patient when they go in. And if you're a sharp individual before the surgery, you're probably going to come out sharp as well. But if you're having some issues with dementia or Alzheimer's, then there's no question we see some changes afterwards.
Yeah, and I'm sure that people ask your advice on this, and that's why you're saying this.
They do, but again, I defer that to the anesthesiologist because there's reasons why maybe you shouldn't have a spinal. Maybe you're on a blood thinner. Maybe you have a lot of arthritis in your spine. It's just not feasible to put a needle back in there for the anesthetic.
So there are some other complications. So it's not so easy.
Correct.
There are some complications. And I like the fact that you really want to find out a lot about that patient because this isn't just you have everybody work them up, you go in, you do it, and then you're gone.
Right.
Right?
You have to treat the whole patient, not just the hip or the knee.
Yeah. And how long let's talk about pain medication when you get out of this. There are different kinds,
Right.
and there's morphine, of course, and there are other things. Do you have a specific type of a medication that you prefer?
I think that if you look at what we've gotten better at over the past 5 or 10 years, it's actually pain management. And what they call it now is multimodal pain management. So instead of taking a patient after surgery and putting them just on what they call the PCA with a pump where you deliver your own medication, that had a lot of issues. Patients are sleepy, they're drowsy, it's constipating. So now we try doing is giving individuals a little bit of several different medications after the operation. You put them on Tylenol around the clock. You put them on an anti-inflammatory around the clock. And then if they're still having pain, then you can supplement it with an oral narcotic. And if need be, for breakthrough pain, you can give them something through their vein like morphine or Dilaudid or similar type of drugs. So if we can minimize the amount of the strong narcotics, then patients are going to do better overall. Less mental issues, less issues of constipation, their function at a higher level, less problems with addiction as well.
I was just going to throw that to you because it seems that's what happens with a lot of people. They were perfectly fine, and all of a sudden they were in pain, and they're given a lot of pain medication. Who would be giving the pain medication? Would you?
Well, after surgery, we will take care of the patients and their pain issues. If it's more than we can handle, then there are pain doctors who get involved.
Because you would see that, wouldn't
Right.
you? You would say,
Yes.
This doesn't seem so right for me. So
Correct.
You do know about that. Well, this really is extraordinary discussion. I always feel so lucky to have people come and share what you do because you don't have the time to usually do this with each individual patient. But when you performed at the Cure Symposium, it was very interesting to watch. I mean, you could hardly keep me from climbing up into the Hannah because it seems so like fun, but I know that it's they go in there before the operation. Of course, you don't carry them and put them in.
No, they're brought to the operating room, they're put to sleep, and then we transfer them to the Hannah table.
Oh, you do?
Yes.
So that's the way it is. Well, Dr. Janke, this has just been extraordinary, and I really thank you very much. People will really look forward to meeting you and seeing you, and that you took the time to do it.
Thanks for having me.
Thank you so much. Bye.